Now starting. All attendees are in listen-only mode.
Division Director for Legal Affairs for the Division of Professions and Occupations. The Division of Professions and Occupations houses many boards, but as relevant today, the 7 prescribing boards that joined together to develop this policy. As a representative of those boards, we are excited to get this policy rolled out. This is the product of nearly 2 years of stakeholder engagement and working with experts in the field, and then a collaborative effort between the 7 boards to put out a policy that is a revised policy that is more comprehensive, includes really the why, and that was the goal of this policy, was to make sure that the public understood the reasons for the recommendations, and also to add in some components that were missing from the first policy. Some of the key recommendations in this policy include alternatives to opioids. What the research has shown is that really the most effective way to combat the opioid epidemic is to avoid prescribing them in the first place. What we looked at here were the different alternatives, both pharmacologic and non-pharmacologic alternatives, and I think that was a key piece that we had missed the first time, was how do we address it on the front end before it ever becomes a problem. Another topic that we introduced this time was reducing the days of treatment for acute pain. The literature has shown that with every day of treatment of opioids, the risk of addiction increases. Also, your concern is every time that a patient is taking opioids, there's certainly the risk of overdose. And so reducing the time of treatment for acute pain to really 3 to 7 days is what the evidence shows is effective. And that does not include traumatic pain or surgical pain. Assessing functionality. Again, that was something that we didn't hit in our first policy. And it's been shown, and multiple even state departments within Colorado have shown that using functionality as a measurement rather than only a pain scale has been shown to decrease dosages and overall use of opioids. The one key piece that seems to be effective in managing opioid treatment is partnering with the patient. Sitting down with them at the beginning of the treatment and setting out functional goals, talking about the risks and benefits of opioids, and developing an exit strategy, making sure the patient knows that opioids this is no lifetime medication, this is something that we're using to achieve a functional status. The other thing that I think is important is the frequent rebalancing of the risks and the benefits of opioids. And we've developed through the policy several areas where that rebalancing should occur. But I think the message that the policy tries to send out is that is an assessment that should be occurring very, very frequently, and making sure that the benefit to the patient outweighs the risk of death or overdose. Collaborating with mental and behavioral health has been shown effective in reducing addiction or treating addiction and reducing unintended overdose deaths. We have recommended that on initial screening of a patient, if there are risk factors for behavioral or mental or psychological health issues, that you contact and seek referral from a mental health specialist early in the treatment. And then finally, actually naloxone prescriptions, concurrent naloxone prescriptions with opioids should always be considered. There's obviously a concern about costs for some patients. Narcan treatment can be substituted, and that's much more affordable for patients. But particularly when you start getting over 50 morphine milliequivalents a day, it's really something that should be more than strongly considered. It really should just be your practice. And then finally are our bright lines. And that's where we set the lines where the risks, through the evidence and the literature, the risks are far more likely to occur at these bright lines. And so we went ahead and set those out in the policy. What's important is that the public and licensees understand that bright lines are not saying this is as high as you can go or this is the only formulation you can give. The bright lines say this is when you need to stop and really assess what's going on and make sure that the benefits outweigh the risks. The bright lines that are set are doses of 50 morphine milligram equivalents a day. Anytime you're going to use long-acting or transdermal formulations. And then duration. If you're going to go over 3 to 7 days for acute, non-traumatic, non-surgical pain, anytime you're treating a patient for subacute pain that goes over 30 days, there needs to be a reassessment and make sure that there's clinical improvement for the patient. And then finally, 90 days for chronic pain is when that evaluation needs to occur. With that, I want to open up the session for questions. We want to make sure that everyone's questions are addressed so that there's a comprehensive understanding of the policy, its intent, and its application. Question?
Is it?
I'm sorry?
So what you just told us about right there is a summary of everything that's in this pamphlet?
It's a broad summary.
So it's just broad. This is all the not anything covered.
Can you be more specific?
Well, yes.
Oh, yeah. Yes, I'm sorry.
No, that's fine, and I'd stand if I could. No, one of the things is for responsible chronic pain patients, because of they're not laws, they're just advisement from the CDC, the DEA, some nurses, doctors, veterinarians, and pharmacists have gotten together and said this is what we need to do to get rid of this opiate crisis that America is going through right now, to try to cut down on the overdoses and suicides. I'm in total agreement of everything that has been said here today. You know, the people, I've had operations to where a broken leg, 7 days is about all you need. They put a cast on and you're good to go. But unfortunately, I've broken my back several times. I've had my neck broken. I'm not going to go into detail. But I'm one of the chronic pain patients that, due to these, to the advisement that has come down the line, I've had over 60 injections from chronic pain doctors that are basically anesthesiologists that it's working on 5 to 10% of the people. But there's a lot of chronic pain patients out there that used to have a semi-productive life, and now that doctors can't prescribe those medicines that we've been on and we've cut back, we've become housebound. I can't even get up and mow the lawn anymore, you know, do the dishes and run for the couch. But I was hoping, if I do have one suggestion. When you're classified disabled, you have to go to the Social Security Department, and they send you to a doctor that works within the Social Security umbrella. It's not a doctor that you don't know who you're going to see, so, you know, that kind of keeps any kind of tomfoolery out of the anyway, what if the DEA, the CDC, or the Department of Regulatory Agencies would instigate putting in their own fleet of doctors nationwide to where they could see patients on a one-to-one basis, treat every case individually, not blanket the whole country. And that way you're going to see a unbiased doctor that's working for the government, basically, and they can review your case by case by case, and at that time they can decide whether or not you are a chronic pain patient or I'm part of a responsible chronic pain patient group. Because out there right now, there are a lot of people ODing, but everything that the studies have come up with have shown that 95 to 98% of these people that are overdosing have more than 5 different drugs in their system, whether it be opiates, which is just another name for heroin. There's methamphetamine, speed, cocaine, alcohol, of course, and fentanyl, which is really the main problem that's coming in from our neighbors down south. But I think that the DEA, the CDC, or the agencies that are telling us what we can and cannot do, and the doctors are in the same boat. They don't like being told what they can and cannot do, but they don't want to lose their license and their livelihood also for helping their patients because of these guidelines that have been imposed. So this way, once you've seen one of the doctors, not the Social Security, but the ones that have been put on staff with the agencies that I just mentioned, you get a little card that's saying that you've been interviewed, that you're part of it. I'm not against having random urine tests. I'm not against having meetings, support groups, everything. It's showing that out of all the people that have started opiates due to a car accident, surgery, I lived up in Vail. They have 1,500 blowouts on knees daily. And they do a lot of knee surgeries up there. And from the surgeries I've had, you use pain meds for a week, maybe 2, and with physical therapy, you're back on it, or you're off the pain pills. So I'm all for that. Tightening it down. I think there's a lot of suicides going on right now because chronic pain patients are not getting the medications due to these regulations that aren't a law, that have been imposed on our doctors, which funnels down or filters down to us patients, to where we were able to go down to the park, spend some time with your kids at the park, do some other things, drive up to the mountains. We live in Colorado. That's what they're there for, is to enjoy them. My daughter is 10 years old. She's never been up to the mountain with me once in the last 3 years since they've started imposing this. I used to be, to me, I was happy with my life. I couldn't golf anymore. I couldn't ski, but I could get up and mow the lawn. I could fix a part of the house that needed to be fixed. I was a contractor for 35 years, and I was kind of a neighborhood handyman. People had something that they needed fixed. They came to me for advice, and I went and helped them. But I just think that this is still too broad, and in what you had told here today, it's still not addressing the problems that there's. One study said that there's 1.8 million. Another one that I read, they're saying there's over 12 million. The numbers, they don't know. There's 50 states out there. Each state does their own count, and so you're getting information from 50 different places. And when these rules were instigated originally, they were with the CDC and the DEA in secret meetings behind closed doors. Nobody knew about it. So unfortunately, it was May 4th, 3 years ago, I myself went off all my pain meds and wanted to try all of these new procedures and medications that were out there that my doctor had told me that were available. I've had 60 injections, never worked. They actually hit a nerve and they did more damage than I had before I went in. And what happened? They wouldn't address the issue that they did. No, they dismissed me as a patient because they were afraid of a lawsuit. I didn't want them to, I wasn't going to sue anybody. I just, give me a doctor I can go see. There's the pain doctors that are out there, the chronic pain specialists, board certified. They're anesthesiologists that just want you to come in and they give you nerve blocks, cortisone, anti-inflammatories, and when you're done and they aren't shielding any results, they're like, well, there's nothing we can do for you. Good luck, and you're down the road. And I have been in the Denver metro area all my life. I have looked for a chronic pain doctor all the way from the Denver Tech Center to Fort Collins, from Aurora to Golden. Like I said, I've had a dozen procedures. I've been injected over 60 times. They had me on, the primary care physician I had me on over 5,000 milligrams of gabapentin, which took care of my neuropathy. I thought it was great. But I went from 218 pounds to 278 pounds in 6 weeks. I couldn't remember the Game of Thrones episode 2 weeks ago. And then I couldn't read a stop sign from 50 feet. I thought I was getting early Alzheimer's, so I started seeing neurologists. My pharmacist caught it and said that my physician had me on twice the amount that they recommend to do. So I had to slowly come back off the gabapentin, and the neuropathy that I suffer from in my legs is back. But, you know, my eyesight came back. It's a little hard to lose the weight at this age, but, it was one non-narcotic drug that worked. Out of all of the other medications that I tried that were non-narcotic, it tore my stomach up. I had all sorts of adverse reactions to these medications. I've done everything I could not to do the opiates.
Sure.
And now I'm went to see a doctor, and he looked at everything I've gone through in the last 2 years, and he says, anyway, he said that looks like you've been through the ringer here, and this is the only thing that works. But unfortunately, we have a policy that we can't write you the amount that your body needs to have a semi-normal life. So good luck.
So let me stop you there, and I want to address some of your concerns.
Great.
Again, this is a policy. It's not a rule. And the language in the policy is very clear that these are guidelines for physicians. They're tools to help them in their prescribing of opioids, to ensure that their prescribing is safe. There is no prohibition for physicians to prescribe opioids. When I talked about the bright lines, what we're asking is that physicians stop at that dose, not stop the medication, but just see the patient and make sure that the continued use of the medication is in the patient's best interest. But in stressing the functional goals, that helps patients achieve function and stay with a dose that helps them maintain their activities of daily living, which you discussed. Being able to go to the mountains with your family, or being able to drive in a car. Whatever your goals are, that's how the medication should be measured. There is nothing in this policy that says physicians can't prescribe opioids. It doesn't even say physicians shouldn't prescribe opioids. What it says is make sure that your prescribing of these medications is safe.
And I understand that completely. And yes, there are recommendations. It's guidelines to live by. But doctors, are so afraid of coming under radar. They don't want, I went to a seminar that had a Harvard graduate, he was MD, and he said through the whole, his whole schooling, they never once talked about prescriptions. They just left it to the doctor and figured they'd use their best judgment, you know, because they made an oath to help people, and they never covered anything about prescriptions. And now you've got doctors that will not write any prescriptions for any kind of pain medication because they're afraid of losing their license, that they're going to get arrested. There's been multiple, I mean, I don't know what the number is, but there's been a lot of doctors that have been arrested, and some of them probably, you know, were outside the guidelines. But, you know, Colorado's got 3 million plus people. I can't find one chronic pain doctor, board certified, that can do anything to help, because everybody's, you know, you're saying right now that, oh no, it's up to your doctor's decision, you know, so it's up to your doctor. We're not saying they can't do it. There's a shadow over this whole thing, and doctors can't write what they believe their patients need, because even though they're guidelines, the powers that may be are, you know, really riding shotgun on this thing really hard. And that's why, again, the suggestion that the CDC and the DEA, they need to think about it. It makes a lot more jobs for people out there. It puts more doctors to work. And these are people that can work with the government in overseeing chronic pain patients. And if you're not a chronic pain patient just looking to get a buzz on, they're not going to be so apt to go in and try to get by on the doctor, because, you know, that's pretty well done. Now, and one of the reasons is I was watching on the History Channel several weeks ago at one of the two major ports coming into America from Mexico. They have, on the average of 1,600,000 semi-trucks. They have 1,850,000 cars coming through. They can't stop all the drugs coming into America.
Can I stop you there?
Yeah.
I really appreciate your input, but we're 25 minutes into the thing, so I want to just make sure I get to everyone's questions. Okay?
I've been a physician here in Colorado for 36 years, and want to thank you and everybody that's put together this beginning program to address a problem. One of the things, I'm a family medicine physician, one of the things that frequently I'm called to explain, show me the evidence. And one of the things that, you know, it could be 50 morphine milligram equivalents, it could be 100, it could be 200. I mean, there's lots of different cutoffs. There's drug-drug interactions. I mean, it goes on and on. But with institution of this program, what measurement are you doing for success? What measurement of number of deaths, opioid-related deaths? How are you monitoring the suicide rates? And, you know, I think this is a great start, but it's not complete.
So I think we talked about in the preamble of the policy that really to address this crisis, it's a multimodal approach. And there are law enforcement considerations, there are environmental and statistical considerations. We're part of the governor's initiative to combat this crisis. We work very closely with the Colorado Consortium. They are the data gatherers, and this is just one piece. So we don't gather data for just this piece, because really our intent with this policy is to educate a broad range of prescribers across Colorado so that they would feel comfortable if they needed to prescribe opioids. And that's really the intent of this piece. But if you're interested in data, I would encourage you to go to the consortium's website. They have a lot of different information, and on a yearly basis, they send out data.
Looking at data statewide, locally, nationally, the deaths reported take anywhere, if someone were to suicide today, the CDC would get that number into their statistics a year and a half from now. So we're implementing a program that I'm happy to hear about the Colorado Consortium, but I also am worried that you're missing the point. I think a lot of physicians are, it's easy. Hey, 50 milligrams of morphine is it. And that's not what you're saying.
No.
But it can be used in the exam room to manage time. And in managing time where you're not reimbursed, I would recommend that we would consider doing a simple, the PDMP is now in a Excel form. You run a simple program looking for double dippers. And if they're double dippers, you send the person a notification. That doesn't mean they've done anything wrong, but it means prior to going forward and refilling their 360 oxycodone a month, you might give pause. And right now, it's a portal that changes frequently. I write macros for the VA, and it drives me nuts. Every time you change your portal, I have to rewrite a macro. I think the effort that you're putting on the primary care physician that writes the majority of the opioids is onerous. And there'll be shortcuts. You only get 50 milligrams. That's it. Don't like it, go down the road. And what I'm saying is the state can step up. The VA's going to. I've been promoting batch dumps of PDMP data for veterans. And probably in a year and a half, it'll happen. But there's things the state can do to make this workable.
And let me this isn't really the forum to talk about the PDMP, and I understand there are frustrations with that, but recently we just implemented the PDMP scorecard system. And so the state is working from that end. And I understand that. And I understand that it's frustrating for physicians. And that's really the purpose of today, is to be able to help people understand the policy, understand the guideline. And the guidelines, again, they're not regulations, they're not rules. And unfortunately, we can do education and outreach, which is really what we're trying to do, but we can't, without participation, we can't change the mind of the physician who just wants to take the easy way out and say, okay, only 50. We're hoping that people will take these guidelines to heart, and understanding the enormous burden that it is to not only manage pain, but manage diversion and all those other things, and try to get together and do what's best for patients.
Hi, my name's Dr. Jonathan Clapham with the Colorado Pain Society, and I'm a pain physician locally. And I just wanted to say about the guidelines, we know what's out there nationally. This is the best guidelines that are out there currently. So it is a long road to hoe, and it is it's a difficult struggle. It's multimodal, but I can't compliment you enough on these guidelines to say that it's completely evidence-based. It's talking about reevaluating at 50 morphine equivalents, make sure you're doing the right thing, and that's exactly what you should be doing. So, talking about primary care docs, and there's way too much pressure on them that goes beyond what maybe this discussion is, but that is true. But the thing is that what's really failed us is kind of institutionally where we just don't have the education. So unless you're seeking out pain education, it's 11.3 hours for medical schools here for pain training. Less than 1% of our training is spent on pain, where it is the biggest complaint that people go see the doctor for. But the people that taught us weren't taught, and that goes on and on. So now it's really up to us to kind of make up for that gap and really try to get educated. So the idea of the CDC guidelines, and really what Dora was building on too, is that the first line of the CDC guidelines say that this was not meant for, or this is meant for primary care physicians without pain training who find themselves treating with opioids. And in that sense, this makes sense, because if you're going higher, you really need to know what you're doing. I wouldn't be prescribing insulin to somebody if I had 11.3 hours of training. I mean, I did. I'm pain medicine, but I can kill somebody with it, but not treating it isn't acceptable either. But these are kind of the things that we're doing. This is really the one field of medicine that is really anecdotal. And when we pick it up in training, if you ask any doc that went to an American medical school, what was your pain training? You get varying answers. It's were you ever asked the question on a test, a patient comes in who's used heroin with a broken femur, what do you do? These are the things that you just kind of pick up on the fly. So, so these guidelines are a great step forward, and really looking at the evidence and not going with the anecdotal reports. So and this is really the one state where pain physicians have been able to come to the table and actually be a part of this. So we're pain experts, thousands of hours of training, countless years of experience, and we just really appreciate being able to weigh in on this. But this is a good first step. And now, y'all may not know, but there's national attention coming from the American Medical Association, from some other groups and legislators and things like that, that we're actually taking steps forward instead of just saying don't prescribe opioids. We're saying we need to get approval for other pain treatments that are not opioids, that are evidence-based, that show that they work, instead of just saying the cheapest option is easily abused opioids. There's some a nice fight, and the one that'll be the most fun that's coming down the road. So so again, thank you for listening to us, and for listening to everybody. We really appreciate it. These are well thought out, very good evidence-based start for people, and that you're not putting a hard cap on people, but just saying, again, look at the function. Are you helping your patients with these opioids? Are you, covering all the bases to make sure you're keeping people safe? That's the most important thing. So thank you again, and we're happy to help as a society in any way that we can. Thanks.
Thank you. I'm going to take a couple of questions from online. Jeanette, you can go ahead with your question. Cindy, if you can unmute yourself, you could go ahead with your question or comment.
Can you hear me?
Yes.
So the thing that I'm a chronic pain patient, and the thing that I'm just not hearing in all of this is there is a crisis in the chronic pain community right now, where people are being taken down to such low amounts that they can't even get out of bed, or they're just being taken off, period. It's just their doctor's just saying, I'm not doing this anymore. Or like what just happened to me, my doctor died, and I don't have a pain doctor now. And trying to get into a chronic pain physician's office at this point is extremely difficult. And even if you do get in, it doesn't mean that they're going to give you the medication. So I've been on this medication now for about 10 years, and I'm just left out in the cold. So I just feel like the chronic pain community is not being heard at all about what's happening in our community. That it's a crisis. It's a huge crisis. I used to do a thing on webinar for people with chronic pain, and we would listen to people day after day after day calling and saying, look, they just took me off my pain medication. I don't know what to do. Look, they've taken me down so low, I can't get out of bed. I don't know what to do. People crying, people saying, I don't want to live like this anymore. And there's been a lot of suicides. You don't hear that side of the story at all in all of this. And I do understand that there have been overdoses. I get that. I used to be a psychotherapist, and I also did addiction counseling. And I do understand that there are people out there that have addictions and have huge problems with this. But the people being blamed and the people being looked at as the people abusing drugs is the chronic pain community. And that's not what's happening. We go in every month, we get our urine tests, we, write a pain contract, we do everything that they've told us to do, but yet they're saying, sorry, can't give you this anymore because of the new rules. And the new rules are supposed to be guidelines. And I don't think that the doctors are hearing that. They're scared of the CDC, very scared of the CDC. And I've had more than one doctor tell me that I'm afraid if I give you this, the CDC is going to come after me. Or I don't give out pain medication anymore. So then you try all these other things that, people on Medicare, they say, go try this, go try that, do these other things, which I've done, spent lots of money that I don't have, and they don't work. So you find the one thing that works, and then now people are saying, well, you're a drug addict, you can't have that anymore.
So I appreciate your comments, and I hear that you're frustrated, and I do want to reiterate that for 2 years we have held stakeholder meetings, and we've certainly heard from the chronic pain community. What we've tried to achieve through these guidelines is to, again, educate additional doctors so that there will be providers that can provide safe opioid prescribing. The purpose of today's session and an entire rollout campaign is to make sure that the licensees in Colorado, and keep in mind, these policies apply to 7 different boards and the licensees there. We're talking to dentists, we're talking to veterinarians, we're talking to...
But are you talking to people in chronic pain?
We have...
I mean, are they a part of this at all?
So we've held stakeholder meetings for 2 years. We've heard the chronic pain concerns, and that is why we're having these rollout meetings to help physicians understand that the guidelines are not rules, they are not limits, they are merely guidelines to assist prescribers in safely treating their patients with opiates if the patient needs that treatment.
But I think what's happened is that many physicians have seen, the being an office being busted for no reason. They come in, they take all of their files, they arrest the doctor. It's just, that's I don't think that's been happening so much in Denver, but it's happening all over the country. So I think physicians are so scared now that they're going to be, they're going to be seen as a doctor who gives out too many prescriptions. And so they're scared and they don't want to do it. Even the chronic pain doctors don't want to do it, let alone just a regular physician. And I think that that's what really needs to be, somebody needs to like totally explain to these people, this is a guideline, this is not a rule, but that's just not happening. It's just not happening. I mean, I hate to say it, but that's the truth.
This is Jonathan Clapp again. I'm a chronic pain physician, but one of the things, and I know what you're going through, and I mean, I see patients all day dealing with the same struggles, and to ask you to get out of bed, for one day and pain that you deal with is unfair for anybody to ask. The one thing I would say, though, is that this is going to be a long road, and especially, unfortunately, it's the longest road for you that are dealing with pain. The idea, though, is that so many things have to fall into place, but you're lucky in one sense in that, from a perspective that you're in Colorado, where this is the only guideline that is in any state that's in place that really leaves the door open to take care of people such as yourself. There's no limit on the opioid number. What it says is to reevaluate at 50 morphine equivalents. The doctors that you're probably seeing, and you can correct me if I'm wrong, but probably are primary care physicians, and to be honest, maybe over their head as far as diagnosing and treating what you're struggling with. What I would recommend, though, is continuing to find a chronic pain physician that can recheck that you have the right diagnosis. I see this more often than I care to repeat, but sometimes you're past a diagnosis that is not correct, and patients struggle for years being mistreated where there could be things that could be fixed. A surgery that went bad when the surgeon tells you everything looks great, but it doesn't because they're, maybe looking at their own work, or, many other examples. And these are, rare, but when you're in chronic pain, it means that we haven't done our job to take care of you. So I would recommend finding someone that can work you up, go over your medications, go over all the options that you have, and then get better. But in Colorado, as opposed to other states, you should be able to get the medications that you need as long as it's making you more functional, able to do the things you can do, not make you loopy, sedated, confused, but keep you cognitively sharp and keep you physically able to do the things that you need to do.
Yeah, so that's absolutely true. And I am seeing, or I was seeing a chronic pain doctor, but he passed away, and the practice is, I'm not sure if it's going to stay or not, so I'm looking for a chronic pain doctor. And it's hard to get in. I mean, they either are full or they just don't want to deal with more people, because there's been so many people that have been kind of kicked out of their GP's office and told to go find a chronic pain doctor. There's just not enough of them in Colorado.
Thank you, Cindy.
Anyway, I said my piece. I'll let you go.
Great.
Thank you.
Do we have anyone else online? Bonnie, you can go.
Hello, can you hear me?
We can.
Hi, I'm Bonnie Wilensky. I'm an advanced practice nurse in pain management. I've been working in chronic pain management for 30 years and as an advanced provider for the last 15. I want to strongly echo what Dr. Clapp had to say as far as the establishment of these guidelines and giving us a really good jumping off place. I do understand the concerns and frustrations of both primary care physicians as well as the chronic pain patient. I've kind of dedicated my career to this, so I'm not immune to what they're feeling. And it is a struggle, and there's not enough pain providers out there, and I agree with all of that. But I think what we're talking about is a question of balance here, that we have to educate people. It's a steep learning curve. I grew up in pain management when there were no limits on how much medicine you should provide. And in fact, the goal was just keep escalating the doses until patients felt okay. And we now know that that's harmful for patients. So much the same as any other physician, once we get new information and new guidelines and new strategies to use, we have to pass that on to our patients. And so what I tell my patients a lot is, if I were your cardiologist and I had you on a medicine that was either deemed too large of a dose or no longer helpful or had too risky side effects, you would expect and you would demand that I make a change. And now we know this in pain management, and so you come to me as a specialist with a certain level of expertise, I would hope, and that I'm going to keep you safe. But making changes is appropriate. And so I try to educate my patients as well. But people misinterpret some of these guidelines, and you're right, they think it's a hard stop. We also get pushback from insurance companies where they put limits. And I think a lot of what drives that is not so much the guidelines, unfortunately, although they use that as rationale, but it's more cost savings for them. And as Dr. Clapp indicated, we need to be able to get approval for those other treatments that can be beneficial to minimize or even eliminate the use of opioids, since this is risky business. I work hard to keep my practice and my patients safe. And I love my patients and I love caring for them, but I also have to balance that with keeping myself, my practice, and my license safe. So that's all I want to say.
Thank you, Bonnie.
Yes.
Thank you. Anyone here? Wait for the microphone. We're on webinar.
Just real quickly, I'm sorry if I missed this. How is the rollout? What's the campaign? And has it been thought at all about somehow tying in the review of this to the licensing application or reapplication so that people have to read it and have to be familiar with the guidelines?
Again, the rollout campaign is such that we're trying to do education and outreach. We want physicians to understand what the policy is and where the bright lines are, but again, that they're not hard stops. Because it's a policy, we're not mandating that physicians do anything. What we're asking is for them to educate themselves and understand the guidelines. Understand, we harmonize these guidelines with the CDC guidelines. They're very similar to the workman's compensation guidelines. They're similar to the healthcare policy and finance guidelines for Medicaid reimbursement. And what we are hoping is that by reaching out to physicians, they'll understand the number of guidelines that exist and make sure that they're using them as tools to help them in their practice.
Yes, you said that over the last 2 years you've been taking meetings and everything. Not only myself as a chronic pain patient, it's my family. Families are involved even as much, if not more, than the person that's suffering from pain. My wife monitors the social media constantly, an hour to 2 hours every day. Anytime that she sees anything, we talk about it in length over dinner and into the evening on anything that she can find out there. And you're telling me that this has been going on for 2 years? Can you possibly advertise? Put something in social media. Let us know when you're doing something. Also, you just took 1.5 years to do this. And again, as the doctors, thank you for the work that's been done on it. And again, as the other doctor said, that it takes about 1.5 years for the info to get there. Now that you've done this and you've made the superiors, they're happy. You had this new guidelines are set. Now we can sit back on our high knees and float for the next 1.5 years. What are the next steps that you see on the horizon that we might?
So I think what you might find interesting is that the original guidelines for prescribing opioids was developed by 4 boards in 2014. After 1.5 years, the board started seeing that there were changes in the evidence, in evidence-based medicine. There were things that we could have highlighted more in that policy. So this is actually a revision of a policy that was instituted in 2014. in looking at the letter that went out with the policy, the boards are very committed to this being a living document, meaning that we will make revisions and adjustments as the evidence-based medicine changes, as there's changes in technology. Is there changes in legislation? There's active legislation across the street that talks about opioid prescribing. And so if that passes through, we'll need to look at the policy and make sure that it is in accordance with new law. So there's really no sitting on our laurels here. It's really making sure that we're speaking with the public, speaking with patients. Now, let me finish. When we did our outreach across the state, we advertised every meeting. Every meeting is sent out to stakeholders. And so if you're interested, I'd encourage you to sign in because that's where our stakeholder lists come from. But we also post them on our website. And so looking at our website is also very helpful. We ask physicians to post the notices so that their patients can participate. We try very hard to be inclusive so that everyone's voice is heard. And I understand that if you didn't see it or if you're not getting the information, that's incredibly frustrating. And so making sure that you get signed up so that we can send you the notices will make sure that you're always in the loop and know what's happening.
The reason I found out today was because my wife checks your site, once, twice a week to see if there's any updates and whatnot. So, and I'm not trying to put a negative thing on this. It is an issue that is important to millions of people out there, and the government machine is slow rolling. It just creeps along. But, we don't hear about a lot of the legislation that's going on just across the street unless you actively get in and look for it. So, but,
Sure.
I do appreciate everything, but,
Sure. And I want you to know, I certainly understand your frustration. And I think when the board looked at this policy, they were very, very, all of them treat patients. They're very cognizant of the patient need to be able to live with the pain that they've been dealt. And very much in the policy, in the language within, it's this balancing between keeping patients functional and keeping them safe. Do we have any online? Okay, we'll do that first. Cindy?
You already got me.
Okay.
Unless it's a different Cindy, I don't know.
Okay, thank you. Okay. Go ahead, right here.
Okay, my name is Nagy Ramsey, and I am a pharmacist, retired now. Nagy Ramsey. I am a pharmacist. I am currently retired. I am a member of the consortium, the Colorado Consortium. And Dr. Kristen was asking about the statistics. There is statistics online relates the PD and MP and a number of deaths, number of admissions, a number of prescription, number of doses. I encourage everybody to go and look them up. Talking with the healthcare provider, they all firmly believe that nobody should be in pain. The whole issue is how we manage the chronic pain. I thank you for having us for sure. My understanding, this is only guidelines. It is not rule, it is not statute. The same guidelines or very similar guideline was implemented in Ohio as a rule. It is a rule, everybody has to follow it, and that took effect the end of August of last year. And so far it has been successful. So just make everybody sure and understanding that all healthcare providers, they have the patient at the front. Nobody should be suffering of pain. Thank you.
Thank you.
Hi, this is Jonathan Clapp again. So again, I'm a pain physician, but to answer what you were asking about, there's been some really positive changes where things were probably at their worst in maybe the fall of 2017. One of the things that first happened, well, I was introduced to the Colorado Consortium, which I think there were maybe 300 people in the room at the conference before that, and I've never seen more dedicated, no agenda, no personal things going on. Everyone just unified and working towards taking care of patients in pain, but also helping people with addiction and trying to prevent it. It was a really and a very powerful group. The Colorado Medical Society set up a prescription drug abuse committee, and which I'm also a part of. I'm in too many committees, but I'm also a part of. But what's been great is when I go to all and sign up for all these things, there was nothing, I was expecting to be frustrated, spinning your wheels like you were saying, and things that move pretty slowly. But there's a lot of really good things that have been coming about. There's a bill that just passed the House that had some considerable input from the Colorado Medical Society, and we were happy to be a part of that too as the Pain Society. But now it's looking to cover physical therapy to make it no more expensive than it is to go see a primary care doc, because there are a lot of patients that have to pay $75, $80 for a PT visit, which can make it prohibitively expensive. And if things aren't affordable, they're useless. So we can't ask patients to pay money they don't have to get treatments that they're not going to be able to afford. So we're getting our foot in the door as far as positive changes to really help patients out, where we're not just going to try to do cheap opioids, but do other things that we can do to help them out. Newer medications that are out, atypical opioids, abuse-deterrent formulations, things like that we can give patients meds, but know that we're keeping people safer. It's all about preventing people from dying and maximizing function. That's really what we're trying to do. But this is the state as far as the country goes for positive change in the favor of patients that struggle with pain. There are other states where they're putting hard, very low morphine equivalent doses on meds, and I don't know how patients are surviving, to be honest with you, with some of these restrictions that are being put on. So it's short-sighted to do that, but just know you're in a state where this was one of the worst states in the country back in 2010, 2011, as far as the opioid crisis goes, and now we've made bigger strides than any other state already with not doing a ton, but now really it seems like the heavy work has been happening in the past 6 months or so. And Dora has been a part of this. And really, this is a huge step towards positive change here. And I know it's slow going, and we all wish it could be faster. But again, I think you're in the best place in the country to really be if you're struggling with pain.
Thank you.
And finally, just asking if Dora can step up the use of technology to offload the primary care physician. There's lots of things software-wise that can be done to make it simpler. I know we've gone from one PDMP vendor to another, and I think that was a good decision. But I'm saying, as a physician, I'm not afraid of the board. I'm happy the board exists. I want to take care of my patients, but if you can save me a dozen clicks, if you can save me 5 minutes a patient, you will be doing your job in making the tools GUI friendly, and will succeed. If you want to charge me an extra $50 a license, I'm okay with that too. It goes up all the time anyway. So, it's the physicians want to do the right thing. We've been backed into the corner by the pain experts that have told us that we're opioid phobic and we need to prescribe more opioids. And now it's the same people are, oh no, doctor, you're not listening. You need to go to 50 milliequivalents milligram equivalents of morphine a day, where before it was 300 milliequivalents of morphine a day.
Okay. We do have someone online. Okay. Kelly?
Muted.
Kelly?
Kelly?
Mm-hmm. Kelly? Hi, can you hear me?
Yes.
Hi. Hi, I just wanted to comment. I very much appreciate what's being done here in the guidelines and recognize what's being said by a lot of the chronic pain patients that it's not necessarily being used as a guideline. I am a mental health and addiction professional, so I see the need for this. I work in the trenches and work in the field and see the absolute need for this. I'm working with it every single day. But I also see the need for some kind of regulation on both sides of it. The regulation that's being put out here today, I very much appreciate, but some kind of understanding and compassion for the human going in and being treated as well. For example, I have an example where a patient went in with an appendicitis and was provided an oral antacid. It was 5 hours before the films came back, before they were provided an opiate for their pain. And then, of course, they were scrambling at that point to make them comfortable. But I think that the pendulum has swung so far to the other end that we need to find a balance. But what I'm hearing today is that this is not a hard and fast rule, that it really is up to the doctor on the other end on how they're going to react to that. So I appreciate that. I appreciate that. So I'm seeing all aspects of that, and just wanted to comment on that I appreciate the state and all the doctors who have put their time and effort into this, and hope that the doctors on the prescribing end can take it as a regulation, because all of the things in here are very reasonable and necessary for us to be able to combat this crisis. So thank you.
Thank you. Okay. Anybody else in here? So I think in closing, the most important things to remember are their guidelines. It is a tool to assist prescribers in prescribing opiates for their patients, or assessing their patients to ensure that opiates are going to help them. I think the other takeaway is for people to remember that this is about more than physicians. This is physicians, it's physician assistants, it's nurse practitioners, it's dentists, podiatrists, optometrists, and yes, veterinarians. And then on the other end of the spectrum, it's the pharmacists. And it's making sure that the healthcare team has a standard set of guidelines so that everybody's operating from the same point. With that being said, it's understanding that every patient is different. And so using these tools to assess the patient in front of you and making sure that you're helping them achieve their functional goals by whatever means necessary. But always keeping in the back of your mind that the benefits need to outweigh the risk to the patient. We're going to continue. We're going to have additional seminars. We anticipate webinars so that people can click online and look at what we want, again, is that for these prescribers in Colorado to understand the guidelines, understand the intent, and hopefully provide the best care possible to their patients. Because again, everyone is on the same page in understanding that chronic pain patients need treatment. Mm-hmm.
For the chronic pain patients that are out there listening today, could you or advise us as a whole what kind of point us in the right direction? Because most of us, we can't get up and go stand on the state capitol steps with signs like, a lot of other groups, to where we can actively get involved from our lazy boy or our orthopedic bed or our step one bathtub. Something, because there's so many people out there that are in so much pain, their voices aren't being heard. Do you have any suggestions on what might just point us?
So, in my opinion, I think the best group for sort of advocacy is the consortium. And contacting them through their website, you wouldn't need to go to the meetings, but making contact and learning how you can participate. I also think making sure that you or patients, watch our websites, see what's new, what's coming up. Are there new laws? Are there new policies so that patients can be informed? And also looking to see if there's notices for meetings where we're gathering feedback, where we're asking for people to come in and tell us their position so we can consider that as we look, to revise guidelines. Dr. Clapp?
Thanks. I would also recommend, this is a very hotly debated topic in the House and the Senate. So finding your state representatives, state senator, and letting them know. I'll just give you an example because I was surprised by this too, but Medicare wanted to come out with a morphine equivalent cap that they got rid of after just receiving, this is national Medicare. They got 1,000 letters. That's not a lot when you think about how big the country is. And that was enough to change it. So you are being heard. I just think that this is a very hotly debated topic where I think most of the representatives and senators want to do the right thing. And I'd like to believe all of them do, and we'll step forward to do what's right for patients. So send them letters about your struggles, about what you need, so that we can get laws passed and to free up docs, get more availability for you guys. We're talking about things like telemedicine, where if someone's seeing their primary care doc, maybe a pain physician can weigh in on good treatments and things like that, and things they can do. And but if we're going to push insurance companies, if we're going to push other people that are making things more difficult, it's going to take laws to do that. So that's what I would recommend. And the other thing is, education for providers. And we put some references together for Dora if you guys want to use them on Colorado Pain Society's website, so that physicians that want to find training can get it as easily as possible to understand what their tools are and hopefully get a bigger toolbox to be able to take care of patients with pain. Thanks.
Thank you. Sure. Thank you all for coming. And we put up our website here for people to write down the address. And then, also my email address is Karen, Karen, .mcgovern@state.co.us. Feel free to send questions, concerns. I'm always happy to hear from people, and we can, if it's suggestions for the next revision, I'm putting them in a file. If it's questions about the policy, I'm happy to help. Resources that I can help with, things of that nature. So thank you all for coming. I really appreciate it.